Okay, thanks very much, Ibrahim, and thanks, Lucia, for putting me after Thies and Peter. I think we've had quite a large, a big global level overview of the situation as it stands, and the points that are coming clearly from both conversations and both presentations is that we need to get the data. Okay, so processing the data, we're getting somewhere with the methods for that. Politically and in terms of leadership, we're getting somewhere with that. But I'm going to spend a few minutes now just talking about some of how we actually get the data and some of the issues and operational issues that arise in that, particularly reflecting on the use of mobile technology as we move towards using mobile phones to gather the data. So I kind of also realized that up to now, there's not been much said about what the process of doing a verbal autopsy looks like for somebody who's lost a loved one. The areas that do verbal autopsies are places in low-income countries where many deaths occur outside health facilities and often without any contact with formal health facilities. And there's a less formalized approach around it. This is a picture I saw Paul Mee notice this from an entrepreneur who set himself up outside St Swallow Hospital in South Africa. So it's not necessary to have a death certificate to bury your loved one. And there are barriers to reporting. There may be reasons why people don't want to tell us even about the death, let alone have us ask questions about the causes of death. So that's the kind of context that we're working in. And so the only solution, or the most common solution that is used at the moment, is to go house to house. This is a photo from northern Burkina Faso. And these are field workers going out to these houses that you can see and asking, have people died here? So again, this hasn't really changed much from the death searchers who developed the bills of mortality that Peter mentioned in London, going house to house to find who has died. And once you've found who has died, then we start to think, okay, now we can try to find out the cause of death. And verbal autopsy is basically an interview process. It's a survey tool. And here's a picture from Bangladesh where the female field worker is recording information using a pen and paper and speaking to this young mother who's holding a baby. And this image you probably can't see so clearly, but the baby has a black spot on its head, which those of you familiar with South Asia and certain traditions, that black spot has been put there for kind of traditional beliefs to avert evil eye and for fitting in within that woman's concept of what causes ill health and what causes mortality. So the female, the interviewer who's wearing the red sari, she's trying to gather information using a WHO standard tool on biomedical symptoms and signs. But she's trying to get that information from a woman who may not be literate, may not be educated, and has her own worldview of what caused illness. And so this process itself is not so simple as just saying we now have a questionnaire or a tool to use. So briefly, the idea of verbal autopsy is this. There are individuals and populations live in the world and they experience health and illness and death. We then try to gather that information through a verbal autopsy interview to come up with a cause of death, and that's not the endpoint. The endpoint is then to do something with that data, to use it for public health action. This is what often happens, though. We manage to gather the data using pen and paper, and then it sits in folders and gathers dust or gets damp or gets destroyed by other things, which I won't even tell you about some of the things that have destroyed our paper forms. But there's issues of gathering this data, information flowing from those individuals who've experienced mortality to the data collectors, to an office like this. Data, information, and flow is all in one way. And then there are problems of actually processing that data. Physician review is mentioned, and that's probably the most common and long-standing method of interpreting the data that's gathered. But it's costly and time-consuming. It takes a long time often to go from gathering the data to having doctors look at it and come up with a likely cause of death. And so other methods have evolved, and over the last decade or so, various other computer-based statistical methods have been developed that allow us to interpret or process the survey data in a standardized, comparable way. It does well in comparison to physician review. It has the advantages of being quicker and cheaper. And so InterVA is one method that's been mentioned a couple of times, and that's one of those key methods. So these have now been established, and actually they've been recommended as a method to use. They seem to do all of the things that physician review can do, but they're at least as good as physician review, but they're quicker and more reliable. And so, us nerds interested in this kind of thing decided to, well, it wasn't us, but some of our colleagues in Seattle decided to hold a meeting in Bali so we could really think about these issues in a very stress-free environment. And what really came out of that meeting is that this whole area of civil registration, vital statistics, and in particular verbal autopsy, it is a growing area of inquiry. And it has been advanced substantially by the use of technology, bringing in statistics with survey methods and with leadership from WHO and others. And an outcome from this meeting in 2011 was really that these kind of automated methods of processing data, these computerized methods, they do as well as physician review, but they're, like I said, quicker, cheaper, and can be more consistent. And at around the same time, the UN and WHO and other agencies started thinking about how can we take these methods that have generally been used in research circumstances, research settings, and start to use them more routinely to fill this massive gap in cause of death information. And they worked to think about the processes of that and to develop a streamlined, slightly easier and standardized tool for collecting the data. And in my view, three kind of key themes emerged from all of these meetings and ideas. As well as cost effectiveness and program relevance, I think there's the idea of simplicity, the need for the tool to be simple so that people can use it. If it's going to be too complicated, if it's going to take too long, it won't be used. The idea of feasibility, I think, is closely related, but so that people are able to do it in countries where there's very limited time and budget for this type of activity. And adaptability. There's a strong need to have a standardized tool, but we also need to recognize that needs and interests differ between different populations. So we've got the automated tools, we've got the WHO leadership and the streamlined questionnaire, and I think as Ibrahim mentioned in his opening talk, there's been this massive rise in mobile phones. Mobile pervasiveness is the third part of the jigsaw, if you like. With the third part of the jigsaw that then led us to think, well, let's put all these things together. Let's develop mobile phones that can have the WHO tool, can process it using InterVA, and will it be ready and easy to use. And we did that. We worked with computer scientists and the WHO, and it was very interesting. We developed this app called MIVA, or Mobile InterVA. It had all of these certain features like localization. We were able to put it in different languages, geo-referencing. We thought all about the issues of data security. We did pilot testing. And it led to some interesting things, and it continues to lead to some interesting findings and slight changes in what we're doing. We tested MIVA, or this mobile InterVA, in various settings, testing feasibility, and there are no problems. Phones are everywhere. People aren't surprised to see data collection on phones. There are issues and practical steps you need to take in terms of localization of the tool, in terms of translations. But in terms of acceptability, it was fine, it was good. And actually working with not just computer scientists in this, but working with human-computer interaction specialists who are able to observe these kind of field pilot tests and see that compared to paper forms, when you've got the WHO questionnaire with skip patterns, and it says if they didn't say yes to this, go to page 42 and ask question 3B, that's all done automatically on the phone. So actually the interaction between interviewers, who you can see nearest to you in this picture, and the respondent sitting on the floor was better. It was a more civil and more humane discussion during a very traumatic interview. In terms of charging and kind of the other practical issues of mobile verbal autopsies, there were no problems. We were able to overcome all of these either using kind of central charging points or small portable solar panels. But there are a number of issues that did come up, and a number of interrelated issues, which I'll try to summarize here. First of all, that MIVA program that I mentioned was an app, so a standalone computer program that sat within a phone. And to have an app, you need a programmer, you need a computer scientist. And it's probably good that if you are programmers, that you can't read what it says on this cup, but there are issues of meeting glitches, having to work late at night, trying to get things to work properly when you're not really sure what the problem is, and slightly different timescales of working compared to field epidemiologists, for example. And that came about really through this problem emerged as a bigger and bigger problem as the app started to be used more and more. There was a need for contextualization. People in different parts of the world wanted to use it. They wanted translations added. They wanted slightly different questioning. They wanted just lots of other kind of small things, which every time we had to go back to technical expertise to do the programming. That costs money. And actually looking forward and looking for in the long term to continually update, localize apps, and also just the maintenance of an app over time, maintenance of any computer program, requires some money. Another issue, which is not unrelated to all of these, is that this was largely being done by academics, and we could justify this as an interesting and important and valuable piece of research. But as it became more routine, as more and more people started using it, we started to struggle a little bit to say, well, where's the research question as an academic? How can we justify continuing to be part of this? And we could. I mean, we have to just be creative and think of the interesting research questions. So more recently, we've started to use free, more user-friendly, you don't need to be a programmer to use these types of tools to develop data collection tools. So the WHO 2016 tool is available on ODK, which is a fairly simple program that most people can use after a little bit of training. So there we've given actually a lot of the problems of having to rely on technical expertise. We've kind of overcome that. I suppose that's at the expense a little bit of losing control. There may be people now making adaptations to make it so localized that it's no longer a standardized tool. But I think that giving the kind of control and ownership to some extent back to those who use it, I think is a very important and actually much more likely to lead to sustainability and the use of this on a large scale. And then there are two key issues that I want to spend a little bit longer on. The first is this idea of kind of the medical profession and the idea of where verbal autopsies came from. They're there to get a cause of death. And for a long time, there was this idea that they're a kind of surrogate for medical cause of death, and there's kind of medical ideals. And a key part of verbal autopsies traditionally has been this part called the open history, where you listen to a narrative of the events that led to the death and a story, usually given in a chronological order, and it's usually recorded in longhand. And when physicians review verbal autopsies, they often use that part and take that part as the key body of information, a bit like history taking in a clinical situation. I'll talk a little bit about some of the issues of that in the next slide, and then I'll go on to talk a little bit about some of the public health opportunities that are being offered by mobile data collection, but also some of the ethical issues that are arising. So first of all, this is an example of an open history. This is quite a short one, but you can see it's a text, a narrative of the circumstances, signs and symptoms and processes that led to this individual's death. This kind of text you can't record on a mobile phone. You can't type this in. It's not practical to do so. You could do it, of course, on pen and paper separately and record it like that. But we've also started to look a little bit of what's the quality of this data that you get. If you have two interviewers independently recording this information at the same point in time from the same respondent, we've seen that there's a lot of mismatch in the information that you get from this open narrative, much more so than you get from closed questions. Having said that, the information that you get in here is useful, it's valuable, and it may be really important for understanding more about the social aspects and the context of the death. If that's the case, if that's our motivation and what we want to do, then we probably need more specialized methods to do so, rather than putting the open history as part of a verbal autopsy, especially if we want to do it on a routine basis on phones. Another issue about this is if we're not getting particularly high quality information or high quality data from the open history in using it in this way, is it worth the emotional impact it has on respondents? So just again, experiences in field work is that this is the most emotional part of the verbal autopsy interview. Asking the respondent to think back and tell you what happened to them is often the part where the interviewers will have to pause and condone, people will cry. So it's a very traumatic part of an already traumatic interview. So if it's not giving us any good data, should we be doing it? A little bit about the ethical issues then. Any survey that we do is an intrusion of privacy. And we have to think about the issues of consent and the expectations of the people that we're talking to and what they expect to get from it themselves. That's something we face all the time in research, but if we're going to start doing verbal autopsy routinely on a large scale, Are the issues that we tackle in research and research ethics the same as the issues we will need to tackle if we start to do this on a routine basis? And this image then is one I showed earlier about the kind of the process that we've got. But using mobile phones, processing the data on using InterVA, for example, on the phone, creates an opportunity to close this loop, to actually get the cause of death information at the end of the interview. So here we have an opportunity. We can give information back, useful public health information back to individuals. And if you think about it for a while, you can start to see some clear benefits, perhaps, of doing so. However, there are also lots of possible risks. And so with colleagues at the Department of Philosophy here, as well as the Institute for Global Health, we've conducted focus group discussions with VA interviewers, bereaved families who've been exposed to verbal autopsy, but not through digital means, and also with ethics and public health experts in Nepal and in the UK. And the idea, the thing we were exploring is, should we give this information back in real time to the respondents of the interviews? It seems it's problematic, is the conclusion. I always thought the philosophers would have the answer for us, but they don't. There are a number of key issues have emerged. There's emotional distress in doing a verbal autopsy, and there's emotional distress in terms of giving the cause of information back seems to vary depending on the age of the deceased. So this is more about the age of the deceased rather than the respondent. We also need to think about repeated exposures to VA in the VA process. In high mortality settings, it's not uncommon year on year to go back to the same mother who's lost child after child. And we have to think about the ethical and the emotional issues in that. Themes that arose from our focus group discussions were issues of honour, shame and blame, particularly around the causes of death, and certain causes bringing shame to a family. The certain causes that were mentioned were leprosy, suicide, abortion-related deaths and AIDS, although almost any disease will have some degree of stigma perhaps attached to it. So then we need to think, well, who should we tell the cause of death to? We're speaking now to a third party, to a respondent about somebody who has died, who is no longer there. Does the deceased person have a right to privacy, and how do we manage that issue? Issues of guilt and regret are also common, and actually they seem to impact more on women and the poorer people in society, because they are the ones who are seen as for women, the ones who are seen as the caregivers, and if they have failed to give the appropriate care, they start to feel guilt. And for the poorer, if they realize that there are things they could have done or should have done to prevent the death, then that also can bring about feelings of guilt and regret. However, there are expectations from respondents that they expect to get information. When they start to do a verbal autopsy interview, often people think you're going to give them something. And actually, in real life, it's common for field workers to give some advice and to give some kind of feedback, although they won't necessarily know the cause of death. So some sort of dialogue is already happening. And given that Peter mentioned many of these interviewers are high school leavers, we have to think about their skills and capability to give information. A couple of other, very quickly, a couple of other issues that came up, and using quotes, that through people like you, we can learn about our child's death so that the same thing isn't repeated for the next child. So there was an interest and a willingness to know. People wanted to know what was happening, but the risks were also there. The cause of death given is useless because the person is already dead. So this idea that for a long time, there's been no interest in my husband, my sister, my brother, but now that he or she is dead, here you come knocking on my door, asking questions and trying to get information from me. What's the point? Why weren't you here a few weeks ago? If it tells us the reasons, then we will think that this technology, if it tells us 3 reasons, then we will think that this technology is fraudulent. People will stop believing in it. InterVA and most of the automated methods will give us multiple causes of death, often with an assigned kind of probability or a likelihood. How do we convey this idea of multiple causality to individuals? And it seems that if we try to do so in this population, at least, or at least within this focus group, that people will just start to disbelieve the technology. It can't be right. There's also issues then that people will have sought some sort of care, or they will have a belief themselves of what the cause of death was. And if, for example, a hospital diagnosis is different from what the technology has told us, this respondent says that then people will be in confusion. They'll be stressed. So we might create anger and mistrust between communities and those who are trying to measure mortality, and also perhaps service providers. So if we're going to start to do this on a bigger scale and more routinely, first we need to think about these ethical issues. And it's these issues about all of the different stakeholders that are involved, and the danger of breaking down trust needs to be addressed. And it's only going to work on a large scale if the services are there and somehow ready to respond to these concerns. There are emerging challenges. There are legal issues. What if you identify deaths due to homicide? Or what if you identify a pregnancy-related death in a young girl, an underage girl? These legal issues, what should we do? What should field workers do? How should they deal with that? If we're scaling up, we're starting to work in new contexts. I've got some colleagues here in the audience who are starting to do verbal autopsies on mobile phones in IDP camp in Mogadishu. Some of the pictures are here. We need to think then about that kind of context too, and about security of protecting our field workers. Could we move towards using remote verbal autopsies? Could we phone people, perhaps? And we also need to think carefully about coordination. A lot of different groups are starting to do verbal autopsy. What we really can't allow to happen is that the same bereaved families get different people coming and knocking on their door, trying to do the process over and over again, collecting the information for different reasons. So mobile VAs are feasible. Practically we can do it. There's no problem to using mobile phones anywhere. They're the most likely solution to cost-effective scale-up. And they offer an opportunity for timely health service response and public health intervention. And they're already starting to happen. So some of the key issues that I've mentioned and some of the operational issues really need urgent attention. Thank you.